This week on the BackTable podcast.
You give them those first couple of doses, and in my experience, not all, but most of them are going to say, hey, I'm feeling better than I was. I have less pain if they had pain, and very, very limited side effects is typically what I've seen. And that's been reassuring to me to say, hey, like in general, and certainly you have some patients that get more side effects, but in general, these are therapies that because they're so targeted, they are better tolerated than a lot of the older radiopharmaceuticals that we heard about from 15, 30 years ago. And that I think is amazing to see where this field has gone and hopefully where it continues to go.
Ready to bring theranostics into your practice or enhance the program you already have? At Siemens Healthineers, we understand what oncology teams face every day. You're navigating complex treatment pathways, patient data fragmentation, coordinating across multiple departments, and managing rising patient volumes. Adding a theranostics program on top of that can feel overwhelming. That's exactly why we built AriaCore for Theranostics, an end-to-end oncology management solution that unifies radiation oncology, nuclear medicine, radiology, and beyond into one unified platform. By connecting workflows, centralizing patient and imaging data, and enabling real-time collaboration across disciplines, it streamlines the entire care pathway, from referral to therapy planning to follow-up. The result? A team empowered with the clarity, consistency, and confidence to deliver truly patient-centered care. Discover how AriaCore for Theranostics can help elevate your program. Visit the link in the episode notes to learn more.
Hello, everybody. This is Dustin Boothe. I'm a radiation oncologist out in Utah with Intermountain Health and Utah Cancer Specialists. And today we're going to have a great conversation with Dr. Funk, who is the Chief Radiation Oncologist for U.S. Oncology practices in Minnesota. And today we're going to talk about the rise of radiopharmaceutical therapies in our communities. And it's going to be a great conversation. Looking forward to it. Dr. Funk, you want to introduce yourself a bit?
Sure, yeah. So as you said, I'm the Chief Radiation Oncology Officer for the U.S. Oncology Network. I practice in Minnesota, and I've been in Minnesota for quite some time. I initially did some training in St. Louis at Washington University in St. Louis, did my residency for radiation oncology at the Mayo Clinic, and then I've been with Minnesota Oncology in the Twin Cities of Minnesota ever since.
Awesome. And tell us a little bit about U.S. Oncology.
Sure, yeah. So U.S. Oncology is a group of physician-owned practices across the U.S. that all have management services through the U.S. Oncology Network. And through U.S. Oncology, we gain access to expertise and especially business expertise and just the ability to collaborate with other physicians that are in community practices. Most of our practices are out in the community, but we do have some that collaborate with hospital systems.
Fantastic. And it's really interesting as I learn about people's different practices. Every practice has a little bit of a different makeup and in their communities, relationships with hospitals, relationships with referring providers. I serve as the medical director for radiopharmaceutical therapy for Intermountain Health. We're a health system that spans 6-7 states, but I also cover with Utah Cancer Specialists, which is a freestanding center that partners with medical oncologists, neurologists, and everybody does it a little bit differently, especially when it comes to radiopharmaceutical therapy, which is what we're going to talk about mostly today. You know, Ryan, as I've talked with different folks about radiopharmaceutical therapies, everybody talks about it a little differently, and there's a lot of different terms. So I thought it'd be great for us to briefly discuss the different terms that are being used out there and explain them to everybody on this podcast, because everybody's coming at a different level. Some have been delivering radiopharmaceutical therapies for decades. Others are just getting into it. Others are also just trying to understand the field. So can you tell us a little bit about the different terms that are being used to describe these therapies and how you use them as well?
Sure. Yeah. So I think the big umbrella term is going to be radiopharmaceuticals. Radiopharmaceuticals is just going to be like a radioactive drug in my mind. You also hear the term radioligand therapy, and that is going to be a little bit more targeted. And so that's going to be a radioactive drug that has some targeting capability, often a short peptide or another small molecule. And then you'll also hear the term targeted radionuclide therapy. that is, I think, just a little bit more broad. And so while the radioligand therapy may not include an antibody conjugated or connected with a radioactive molecule, a targeted radionuclide therapy, that can include both.
Fantastic. And one thing that I didn't quite realize until I really got into this is that radiopharmaceuticals can also include a diagnostic too, right?
Absolutely. Yes.
So, for example, a PSMA PET, you inject a patient with a radiopharmaceutical that's used to target, and then the therapy is also radiopharmaceutical, but on therapy side. Just something that a little pearl for those who are trying to speak the language here. So today we're talking about the rise of these radiopharmaceuticals, and I was wondering if you could share with our listeners a little bit about the current wave of interest that's really come about recently over the past few years, and where this has come from in your perspective.
Sure. So I think this is actually a really neat story. And in preparation for the podcast, I actually did look up a little bit because I was like, we've all done radioactive iodine, often in training, if you're a radiation oncologist or a nuclear medicine doc. But outside of that, many people really haven't heard about this or thought about it much. And so radioactive iodine was the first radiopharmaceutical that was FDA approved, and that the investigation into radioactive iodine is actually in the 1940s. So that's something that's been around for 80 plus years, which I didn't realize it had been around for that long. And radioactive iodine, it is highly utilized in the thyroid, and they took advantage of the fact that iodine in the body concentrates in the thyroid in order to treat conditions like hyperthyroidism or some thyroid cancers. It took quite a while before more was built on that. And as you get into the 90s, there was strontium and samarium, which were agents that primarily aggregate in the bone. And they were used for what we call osteoblastic bone metastases. Osteoblastic, as you know, just means that the bone really starts to lay down a lot of calcium. They kind of took advantage of the fact that, hey, the bone is laying down this calcium, and strontium and samarium lay down in the same area. But those medicines had a fair bit of bone marrow suppression. They never really gained widespread popularity, or at least they seemed to die out. Next came some radioimmunotherapy, so Bexar, Zevalin. These are medicines that, again, we don't use quite as frequently now, but they were using an antibody to take that payload, take the radioactive molecule, and address things like Hodgkin lymphoma and non-Hodgkin lymphoma. Again, just because of the way they were designed, some hematologic toxicities, so those have also kind of fallen a little bit more out of favor as other targeted therapies have come on board. More recently, if we look in the past probably 12 years or so, that's where we start to see kind of a shift and a new way of thinking about radiopharmaceuticals. So the first one would have been Xofigo or radium-223. And radium-223 is unique in the radiopharmaceutical world because it gives off a different type of radiation. It gives off alpha particles. And comparing that to strontium and samarium, that alpha particle creates a lot more damage very close to where it gets deposited and a lot less damage. It doesn't travel as far. And so you get a lot more dose into tumor. Again, this is for osteoblastic tumors, specifically for prostate cancer, compared with tumors elsewhere. And that is actually now being examined for other types of osteoblastic indications. And then we now in the more recent years, we've seen Lutathera and then Pluvicto being the most recent, which are going to be those radioligand therapies where you've got a small molecule that targets a radioactive, in both of those cases, lutetium, into the target tissue. And it's that targeting, I think, that is really creating a lot more interest because now your therapeutic ratio or your therapeutic index is much greater in the fact that you get a lot more bang for your buck.
Yeah, absolutely. Well, that's a fantastic summary, Ryan. It's like you, I found it really fascinating where we've come, where we've been, and where we're going in this field. And it seems like lately it's, I was a part of the when radium-223 came out and the excitement along that line. But it seems like lately it's a little bit different. It's a little more momentum in the field compared to previous launches of different platforms and drugs. Why do you think that is? I mean, is that just me, or do you feel that way too?
No,
as well?
I absolutely agree with you.
Yeah.
I feel the same way. I think for me, the excitement is a lot around the ability to target these therapies, right? One of the things that we commonly talk about in radiation is the therapeutic index. And for listeners that may be less aware of how we think about things in radiation, for external radiation, when we're treating from the outside and shooting beams of radiation, you end up treating other parts of the body with some radiation. And so we're always looking to try to say, well, what amount of dose can we safely give without causing side effects, because we know that some of the nearby tissue is going to be affected. And what these newer targeted agents are allowing us to do is increase that therapeutic index or therapeutic window, where the dose to a specific target can be really high, and yet the dose to other targets that we don't want to hit can be significantly lower. And I think, similar to some of the other targeted therapies that we're seeing in other oncology specialties, this just has lots and lots of potential compared with some of the prior ways of going about it. I don't know, I'd be interested to hear your thoughts on that.
Yeah, no, totally. I think we've had a proof of concept of this platform where you've got this payload that works, that kills cancer cells in the radionuclide, and then we've gotten better and better at the ligand component of it. Being able to target is just as you're saying, and I think that's been a proof of concept with Lutathera, but Lutathera being for neuroendocrine tumors, less common tumors. And then having that escalated to the next level of showing that this platform can now address one of the most common cancers out there in prostate cancer. And then seeing that go from post-chemotherapy and castrate-resistant to pre-chemotherapy, now additional data in the hormone-sensitive setting, some additional data in oligometastatic and upfront hormone-sensitive, and suddenly we're seeing this proof of concept play out in real time in very common malignancies, which are really exciting. Then you're also seeing just like this huge investment of then trying to perfect each side of the equation, a little bit more, you mentioned radium-223, use of different radionuclides like alphas that have a shorter length, deposit more energy, potentially more efficacy. And then you've got these ligands that are really taking advantage of that therapeutic index, becoming more sensitive, more specific to these tumors. And at the same time, what I think is really cool compared to how we've looked at these in the recent past, and it's more analogous to what we've done in thyroid cancer, but we've had the advent of these imaging technologies at the same time.
Yes.
And suddenly this companion relationship, we're able to use these images in a really unique way to predict response, to potentially use, and we'll talk about this more in the future, but use radiation for external beam radiation in areas that aren't getting dose and things like that. But I agree with you 100%. It's really been cool to watch the evolution over the past few years, right? Since the launch of Lutathera in 2018 and Pluvicto in 2022, it just seems like there's an explosion. There's so many additional targets and things that are on deck.
It's that confluence where, as you said, we're able to image, so we're able to see things. And then as soon as we're able to see them with some of these newer platforms, we're also going to be able to target them, which I think is fascinating and fantastic.
Yeah. Awesome. You and I are both radiation oncologists, and as you mentioned earlier, in order to deliver these therapies, you need an authorized user. Can be a radiation oncologist, can be a radiologist, most commonly a nuclear medicine physician. But you and I are both radiation oncologists, which in the community setting, I have found has been relatively more common, I would say, and I think that probably anchors in just to how radiation oncologists fit into the community over the last few decades, incorporation in multi-specialty groups and hospitals. But let's talk a little bit about radiation oncologist role in your opinion and in managing these therapies, how you see this role has developed over the past few years and will continue to develop. So radiation oncologist managing a systemic medicine. How do you see that platform, that advent, that we are now players in the systemic therapy space? Tell me about your perspectives of in your health system in U.S. oncology, how you've seen radiation oncologists had to shift a little bit and think in terms of systemic therapy, and what sort of growing pains or adjustments that you and your fellow physicians have had to make in these therapies, if any.
Yeah, no, I think that's a great call out, right? Because as you look at the development of radiation oncology in general, most of what we do are going to be targeted therapies or directed therapies that address only one part of the body. But we've always really done that in a larger context, right? So many of the treatments that we give, we're going to give chemotherapy and radiation at the same time. And so even though we might not be delivering that systemic treatment, we are oftentimes thinking systemically, because where we treat and how we treat with external beam radiotherapy often encompasses not just like the gross disease, the disease that we can see, but we're often developing external radiation fields in ways that encompass microscopic disease as well. And I think as I think about this is to me kind of an extension of that larger paradigm. Where it's a little unique is most of these therapies thus far are indicated in patients with widespread metastatic disease. And so for me, when a patient comes to me with widespread metastatic disease, I'm often just helping with one part or another part because it's causing pain or threatening function. Whereas this is a therapy that, as you said, it's systemic. It goes throughout the entire body, treats the cancer no matter where it's at. And I do think that in this setting, there are some things that you need to think about a little bit differently, and that our radiation oncologists in the community are thinking about differently. One of those things is side effects, right? As we think about a systemic therapy versus a very targeted course of external beam radiotherapy, now you have to think a little bit differently about side effects, fatigue, and bone marrow suppression, those types of things. But you also have to think about effects that are going to happen outside of your intended target, right? So for Pluvicto specifically, thinking about things like dry mouth that may persist after your treatment and may have implications further down, as you go to ongoing therapies. I think additionally, as some of these therapies pull forward in where you deliver them, right? So for Pluvicto, as it's gone from post chemotherapy, post androgen receptor inhibitor to now pre-chemotherapy and perhaps even earlier, I think you do have to be a lot more cognizant of things like long-term kidney function or other things that you might affect. I think the other thing is how the referrals start to come in, right? Many times in an academic practice, often these referrals may go straight over to nuclear medicine. And in many of our private practices, there may not be that nuclear medicine doc that's going to take over or deliver Pluvicto or Lutathera. And so these are coming to radiation oncologists. And I think that's a good thing, and in the sense that we have a lot of experience looking at kind of a whole patient and saying what's not just the thing that we're looking at right now, but where is the overall picture of this patient's cancer, and how does this particular therapy fit in versus what are some other options? Because there often are other options for these patients.
Yeah, you bring up some great points. And as a fellow doc in the community, I've noticed that I've had to work with my medical oncologists and urologists in a different way than before. We give concurrent chemoradiation often, and there's often that collaboration. But often I just feel like in those settings, those patients, it's like I've got my corner, which is the external beam,
Sure.
and you've got your corner, which is the systemic therapy. But here we're both working on the same side of the equation, looking at labs together, making sure that all these side effects are being appropriately managed, that they're not being missed. I've also found in my practice that every referring doc is a little different, right? Some want to be really involved in the management and will want to see the patient routinely in between cycles. Others will just say, hey, Dustin, just take care of it. Have you noticed that as well?
Yeah, I think it varies by practice. In my own practice here in Minnesota, I'd say most of the docs are going to say, yeah, you go ahead, you deliver it. I'll see them maybe halfway through, and then I'll see them when they're done. And then I've got other practices, in other parts of the country where either the medical oncologist or sometimes the urologist do, just like you're saying, they stay very, very involved, and they're up on top of the labs. And yeah, I think it's a rapidly evolving field that will likely change. 10 years from now, the way we do it now is probably going to be very, very different.
Yeah, no, I agree with you. One thing that I've noticed in my practice, and I'm curious if you've had a similar experience, is I get to use both sides of my brain with these patients. And by both sides, I mean my external beam side and my systemic therapy side, which to me has been really rewarding and interesting. And I'm curious to know how you've integrated the radiopharmaceutical patients with external beam, and what strategies have you used for these patients?
Sure. So it's interesting as I talk to other physicians around the network that are doing a lot of this as well. That's one of the things they really like. And I personally have had patients come in where the referral was, "Hey, we want you to treat these, 5 or 7 bone mets." And the referral comes in, and they've been on an ARPI, they're progressing, they haven't had chemo yet, and I look, and I'm like, well, sure, there are these 5 that I might be able to treat, but there's 6 more that are also progressing. And then that's been an opportunity for me to go back to the referring physician and say, hey, actually, have we thought about this option, Pluvicto in that case often, as a different way of addressing not just the ones that the radiologist called on the report, but also the other ones that appear to be progressing. And then I've had the opposite happen as well, right? So I've had physicians come and say, "Yeah, what do you think about this? Can we give Pluvicto?" And as we talk about as a group, sometimes there's only one site that's progressing, and everything else is really not doing anything. The patient feels great. We say, let's hold off on Pluvicto for a couple of months and let's treat that area, and we'll see how long we get. And sometimes we can get many, many months where we can save Pluvicto or other therapies for a later point in that course.
Yeah, I love those patients, those scenarios, right? I've got one right now that I just finished his SBRT plan that presented that exact same way. Referred for Pluvicto, looked at the scans, saw there were only 2 lesions. He had been in the hormone-sensitive setting for quite some time, like 3 or 4 years. So already kind of this indolent process compared to other types. And we had the discussion of like, hey, let's just target these 2 areas. And then, there's a chance that you could have progression outside the field, but given your prior behavior, the prior behavior of your cancer, I think it's very reasonable to address these areas and put them down the line. I think those are really rewarding patients.
Yeah. And I think that's a great example of what radiation oncology can bring to this field, right? Because we do have both of those sides of our brain where we can think, hey, should I zap this or should I zap it in a different way?
Yeah. That's right. I've also found that I've had a number of patients with need for palliative radiation or even prophylactic radiation. I've had patients that have been referred to me for Pluvicto and then found a large lesion in the femoral neck that was at high risk, right? Or patients with really bulky spinal disease with the posterior elements involved, with kind of some nagging pain and kind of in that area, where just like, hey, I could start this radiopharmaceutical therapy, but that looks really bad. So why don't we treat that? And there's, as you know, there's emerging data on treating areas of high risk, that Sloan Kettering data, the ongoing NRG trial, looking at treating areas within that are high risk in the spine and the pelvis. And I'm really interested to see how those data mature. Yes. And because I think that there's potentially a risk or a role for treating these high risk lesions in addition to the areas that are symptomatic.
Yeah, I would agree with you. And I think we've seen a lot of that with other targeted therapies, with immunotherapy and other things where oftentimes that targeted therapy, and again, we have to wait for data, but oftentimes some of these more systemic, even though they're targeted, big lesions, scary lesions, targeted external radiation can often help get you to where you want to go without increasing a lot in toxicity.
Yeah, and I'm not sure if you've had this experience as well, but also when patients progress, sometimes they're progressing, symptomatically, and knowing that the next line is docetaxel or cabazitaxel, and knowing how long it takes those therapies to have an impact on their symptoms, I'm also doing it on the back end, right?
Absolutely.
And I feel like that's ultimately, I feel like that's good care, right? We're keeping these patients mobile and, their pain managed as they transition out of these therapies. And to me, that's part of the fun of this. And I have folks that say, hey, why would we do this? Maybe the financials aren't as great. And I understand that. We'll go into that later. I've personally seen that using external beam therapy more and that translates into better outcomes.
I think being able to see the whole patient, see the big picture really helps in this space.
So next I wanted to talk a little bit about startup and practice development. We may have some listeners out there that are considering starting a program or advancing their program, and you have a unique perspective in your leadership role within US Oncology, seeing a lot of different sites that approach this differently. I also have some experience on my side. So can you share with our listeners here some of the barriers that you've seen to starting a program and how you've seen practices overcome those barriers?
Sure. I think one of the biggest barriers is that what I'll start with is the financial side of it, because as you kind of mentioned, reimbursement can be good, it can be bad, it can be indifferent. And I think because of the current expense of a lot of these medicines, oftentimes as practices look and say, hey, should we do this? It's not so much the startup costs in terms of the hot lab and the other things you might need, but it's the insecurity or fear around reimbursement is still, I think, there. As we look at Lutathera and Pluvicto, which, those are the two biggest ones right now, we've seen pretty big increases in cost, and the structure around how do we pay for really expensive things in medicine is getting better, but it's still, somewhat of a concern. And so I think oftentimes as we looked at it, specifically in Minnesota, we looked across the US Oncology Network and we said, hey, here's a practice in a different part of the country. They're doing really, really well. We looked at their financial and said, hey, okay, we think we can make this work. And then right before we were about to launch, we looked at and we were looking, locally for them, just what they were getting reimbursed. And we looked locally for us, what would we get reimbursed? And it turned out that we were underwater with Medicare. And that's been corrected in the time since. But that was whoa, hold it, we can't do this, because most of these patients are going to be of Medicare age on some sort of Medicare funded plan, and so we really had to step back. And so I'd say that's one of the first things is you need to have somebody with some expertise looking to say, okay, this is what it costs to acquire the drug. This is what the reimbursement is going to look like. One of the things that we've done within our network is we put together a playbook or a toolkit that essentially runs through the operational and business side of things. So everything from how do you acquire the drug? What does the drug cost? How do you get reimbursement? How do you get prior authorization? As you know, that can be very, very important, especially for these higher cost drugs. But also, what are the nuts and bolts of setting up a hot lab if you don't have one? How do you make sure that you're partnering with somebody that can do the relevant imaging if you don't have that capability in-house? How do you advertise this? How do you get the referrals? And all of those questions are going to be a little bit different depending on your setup. Most of our practices are multi-specialty, and so most of the rad oncs are going to be paired with some medical oncologists and in some cases, urologists. And so either you're building existing relationships, you're educating others to say, hey, here's this newly indicated molecule. This is when we use it, how we use it, but also to say, hey, come, send them to us. We'll take good care of them, and we'll make sure they get the appropriate care. I'm interested to hear from your side. What are some other things that come to mind?
Yeah, absolutely. You hit on some really important points. And this is actually something that's been really fascinating to me, because 3 years ago, I didn't care that much about drug reimbursement. And I didn't really care about it too much until I worked with Astro on some things. And I saw that it was a big barrier for folks starting programs. Just the fear of it. There were a lot of misconceptions, but also some truths with the early days, with the challenges and reimbursements, as you said. And so some of those things have been fixed, but there's still challenges. And those fears has resulted in an access problem. Now, I think that has largely been resolved over the past year or two, but I think it's still there in some settings. And I've also been involved. Part of this need led to being involved with a purchasing network. It's called CUNY Theranostics, and I was helped to co-found that to help to decrease costs for these practices and help them understand kind of the pro forma of this. And I think one of the bigger challenges is, as you mentioned, some of the MACs or the Medicare contracted organizations that are actually set the reimbursement after the price increases. You can have these really long lags.
Yes.
And so that can result in the margins being quite thin for a period of time.
Or negative in some cases.
Yeah, absolutely.
Depending on how big the jump in price was, and depending on what the contract previously was. I agree with you. AWP, ASP, those were terms that most radiation oncologists, I think, just didn't pay attention to previously, and now those are terms that most of us need to know if we're going to be active in the radiopharm space.
Yeah, absolutely.
I think some of the other things I've been surprised with as we've started up various programs is tracking these patients is very different than tracking an external beam patient, right? So for me, when I prescribe external beam, that is very well developed. I prescribe my dose, I sign off on a plan, develop the plan, sign off on the plan, and then it pretty much runs itself. It gets delivered, and there's weekly OTV visits, and that's about all that we need to do. Whereas for these patients, there are labs, there's often imaging that goes with them that you both need to pay attention to prior to delivery, but also during that delivery. And you have to be able to track the patient through that. And so some of the software solutions out there are as rudimentary as an Excel spreadsheet or a whiteboard where you're writing out names and dates and trying to track things. And I think that's one of the areas where there's been a lot of growth. Things like AriaCore looking to try to streamline some of that for providers that are providing these sorts of things. So I'd be interested to hear from your standpoint, where did you guys start in terms of how do you identify patients, how do you track patients, and where are you now?
Well, for sure, practice startup, once you get started and you do the financials, you realize it can work, and sometimes you can, especially with commercial contracts, and then you get your RAM license, you get everything organized. Then you're like, okay, now how do I actually work with my team to do this? And as I said, I work in a hospital system, then also in this freestanding center. I found that nurse navigators are really crucial, and it doesn't have to be that specific title. Sometimes it's just your nurse, right? Or your nuclear medicine technologist or what have you, that helps be that anchoring kind of focal point to help collaborate with referring providers, helps patients. And honestly, there's not a ton out there. Hasn't been a ton out there specifically designed to help us follow these patients, communicate with our nurse navigators, communicate with our referring providers, making sure these patients are getting their labs at regular intervals, scheduled for appointments. And so, there's different things that are being put out there. I love how radiation oncology companies are starting to pay attention to this and integrate into what we do already. And that's, important to build on what's already there. I think that has a lot of value, right? And so I'm excited to see what's going to be developed and rolled out, because I think that there's a need there to build on, rudimentary systems, Excel spreadsheets, random meetings that are set up with your nurse navigators. An appropriate system that matches the therapy is important, and to build on what we do as radiation oncologists is, something that's really important, I think. So I agree.
You mentioned like a person to run this, and I agree with you completely. As I've looked across the U.S. Oncology Network, the practices that are succeeding in doing this, one of the common themes is they've got somebody that's kind of watching and following and helping shepherd patients through, because it takes usually a nurse or in some cases an APP, or it varies with who that person is, but just having somebody, usually not a doctor, quite honestly, that can, make sure labs are at the right time and imaging gets followed up is really important. You mentioned authorized users and RAM licensing, AUs and RAM.
Yeah.
For the audience, maybe we should define that a little bit, because absolutely you cannot have a practice without a radioactive materials license or the RAM license or an authorized user. So
absolutely. Authorized users, these are physicians who have been authorized by the NRC underneath the umbrella of either agreement or non-agreement states to deliver these radiopharmaceutical therapies. Typically is a radiation oncologist or a radiologist, most common being a nuclear medicine physician, although a general radiologist as well as interventional radiologists, if they have the appropriate training and accreditation, can do it. Authorized user availability is a really interesting challenge that some areas have because there are cutoffs in terms of training that you had to have and numbers of hours that you had to have. And it's important when you're planning these to open these programs that you look at, what you have been qualified to deliver. And you look at your physicians and see what training they might need, if any. Sometimes, and you may have seen this in the US Oncology Network, but sometimes you have an area that you don't have an authorized user, but you have a demand for it. And, when we rolled this out, we started in Salt Lake City, Utah, our most populous, highest population in our entire kind of system. And we quickly found that we had a ton of patients coming from Southern Utah, but we didn't have a program there. And it took quite a bit of effort to get that RAM license going and then an authorized user that could deliver the therapy. And we could only get one authorized user first. And suddenly that program really exploded. And that poor radiation oncologist is just so busy down there. And we're trying to get somebody on the license to help them, but there's a time period that it takes to get physicians on licenses, and he's kind of swamped, right? And so there are scenarios where authorized user availability can be a hindrance to program development and growth.
Yeah, and I think that's very, very similar to what we've seen in our programs as well. For a radiation oncologist, who is an authorized user as well, they can do both external beam radiotherapy and they can supervise a radiopharmaceutical program. And depending on how the program is set up, sometimes they can do both at once, but sometimes they physically need to be in one place to supervise external beam, and they need to be in another place to supervise radiopharmaceuticals, and that does lead to some difficulties. So as we talk about RAM licensing or radioactive materials licensing, those licenses are typically going to be given by the state. So you apply to this state where you're going to deliver the radioactive materials, and it depends on your state how long that might take. You typically need an authorized user to be on that radioactive materials license, and then sometimes it's a very short window, but I've heard of some places taking over 6 months to get not just like a new RAM license, but even amendments to your license, because depending on the state where you practice, some states are very, very specific, and they'll say you can deliver radium-223, and that's it. And then for you to add something else like lutetium, which is in Lutathera and Pluvicto, you need to amend your license, and that often takes a fair amount of time. Whereas I've had other states where they say, you are authorized for this amount of activity or this amount of, this number of patients, or I've seen quite a bit of variation on that. And so that's one of the things that groups need to be aware of is as they're getting that radioactive materials license, for therapeutic radiopharmaceuticals specifically, the doses are quite a bit higher than if you've only been doing diagnostic radiopharm. All of a sudden, as you go into the therapeutics, it's going to be different isotopes, which may not be covered by your radioactive materials license, and it's going to be different doses. And so you need to make sure that you're good on both sides of that.
Yeah, and I think you've seen, as you mentioned, and we have too, that RAM license can really slow you down and affect your ability to start this new service line, really. And it takes forethought and planning and making sure that you have the right resources to do it. And it can stop program development. I've had sites that it stopped the ability to do clinical trials, right? Because it's a new radionuclide, and that's not on the license. And the way that it was written was so narrow and specific that you have to go through everything all over again. And each state is a little different. And so on that note, tell me about your practice and others within your network about how you are advancing your practice, taking your practice to the next level in terms of clinical trials. Are you doing dosimetry, radiopharmaceutical dosimetry? Is that something that you aim to do? Can you share a little bit about that?
Yeah. So I think first off, the biggest driver is as you get a new practice going is you want to get some volume and some expertise, right? And so as practices are starting to do radiopharm, whether it's my practice or another practice, I really encourage them initially work on getting those referrals. And right now, again, it's going to be Lutathera and Pluvicto, so prostate and neuroendocrine tumors, and really try to do as much as you can to get those volumes up, because I do think there's a lot to be said for being able to generate a program that walks patients through that process as seamlessly and as easily as possible. I also think it's beneficial for providers initially to have some more experience in managing some of the side effects that go with these radiopharmaceuticals. Some of that is going to be questions like, hey, for Pluvicto specifically, what do we do for patients who have a catheter, or what do we do for patients who have an nephrostomy tube? Things that the initial pass as you're generating, your standard operating procedures for your program, you may not think of. Once you've got some volume, I think research and kind of that next level is where it gets really, really exciting. And so my individual practice in Minnesota, we're wanting to make that next step into things like dosimetry. We're planning to start our first trial, but across the network, we have practices that are already doing that. So we've got some practices that have 5, 6 different trials open concurrently. We've got some practices that are starting to just do some dosimetry. And what that is, the dosimetry portion for non-radiation oncologists, that's where not only do we deliver the medicine and just say, hey, it's going to go throughout the body and go where it goes, we then do measurements of where that radiation actually went and how it was delivered. Because between the diagnostic scan and the therapeutic injection, there can be differences in how that's delivered. But also, as you do that dosimetry, you can measure dose to certain organs that might be at more risk for damage than others. So kidney would be an area that we commonly worry about, since it processes a lot of these radioactive materials and kicks it out through urine. And so as you do that dosimetry, you can measure specific doses or accumulated doses through different parts of the body as well as at the targets. And then you can get a better idea of, hey, are we giving enough? Are we giving too much? Do we need to go a little bit more? Those next steps I'm really excited about, but we don't know what the right dose is yet, unless you do. Maybe you've got the inside scoop, but that's where it gets really exciting to me is the current ability is we say, well, for Pluvicto, for example, we give 7.4 gigabecquerels or 200 millicuries to every single patient unless they have some toxicity, and then we drop that by 20%. Where I think it's really, really fascinating where external beam went is you can do some individualized dosing depending on, hey, what's happening to the other normal tissues and what's happening in the target tissue. Have you guys started doing some of that?
Early on in our program, we were the first site in Utah to treat these patients. So we got really busy, and I got really obsessed of where some of the thought leaders were talking about where this field was going. And I really got into dosimetry. I have this awesome physicist, Nikki Mon, who's a PhD physicist at WashU, who also was really interested in implementing dosimetry and clinical trials. And so we partnered really closely with our nuclear medicine department and nuclear medicine physicians who were interested. And we rolled out a SPECT-CT imaging program first. That was like the first step, was like implementing a SPECT-CT. And for those of you who are not aware, SPECT-CT, compared to PET-CT and PET-CT, you inject a diagnostic radiopharmaceutical, a PSMA PET, for example, agent, and then you image it right away, that small amount. Well, in SPECT, what you do is you inject the therapy, and then you just have them come back and you read the radioactivity from the therapy. And I could go into the specifics and the physics of all that, but essentially that's the difference is you look at what you just delivered, and you're literally looking at the dose, where the dose went, that you just gave the patient. And we built that out in our program. We use that for decision making in patients. Tom Hope has some great work out of UCSF and how that has changed their patient management. We built on that. And then once we had our SPECT CT program, we turned our attention towards building radiopharmaceutical dosimetry, looking at different softwares. We ultimately implemented a software that helped us do it. And we use that on cycles 1, 3, and 6. And predominantly, we're using it for dosimetry dosing, making sure that we're not giving too many cycles for the therapy if the kidney doses exceed. And I've had two or three patients now that I've stopped early because the dose of the kidney exceeded the FDA allowable limit to that organ. So, and then clinical trials, we have phase 1 through 3 clinical trials, built out pharmacokinetic capabilities, PKs. And it's been really cool to be engaged in these early trials, looking at new targets, new isotopes. And ultimately, I think that's what gets you really excited, is helping advance the science in the community.
Yeah, I think that's where, like, you look at some of the pipelines that come out, and I think we've all seen various examples of, if you just Google radiopharmaceutical pipeline, you'll see, Lutathera and Pluvicto in the center, and they're, FDA approved. They've gone through phase 3 trials, and then you go to phase 2, phase 1, and like preclinical stuff. And as you look more and more out there, that's, I think, where a lot of radiation oncologists get really excited, because we look at that and we say, oh my goodness, like, look at these opportunities. How many more patients are we going to be able to have where we put on both of our hats and we think, oh, well, should I do some external beam? Do I get to save the external beam and use a radiopharmaceutical? And I think over the next 5-7 years, we're going to see more and more of those get pushed closer and closer to kind of that phase 3 space where, hey, now we've got really good data that says this is something that works and helps in new and interesting indications.
Yeah. So where do you think it's all going to go? So 10 years from now, Dr. Funk, what does it look like? What does radiopharmaceutical therapy look like compared to what it looks like today? We've mentioned some ideas, but give us a prediction of what it looks like.
Yeah, I think first off, I think what I can safely say is that the number of indications is going to explode. I think that's very clear. The number of trials that are going on, some of them are going to be positive. I hope most of them are positive, but as we know from drug development, not everything will be. So I think there's going to be a lot more targets, a lot more indications, various scenarios. What I'm really hoping to see, and this is where it's, I think, harder to predict, is that these drugs move earlier and earlier, and maybe they become part of an adjuvant therapy, or maybe they become part of first-line metastatic therapy in more and more indications. Other things, I think what I hope is that we get better and better therapeutic index. I think we haven't seen an alpha emitter other than radium-223 come out that is targeted, radium targets the bone, but something like a Pluvicto or a Lutathera, where you've got an alpha emitter radioligand therapy, I think would be very, very neat to see. How does that compare with the beta emitter of lutetium in terms of the therapeutic index? I think many of us, as we went from kind of the 3D era to the IMRT era, will remember these arguments that, hey, you need some of that dose cloud or that dose wash to treat microscopic disease. And now many of us use SBRT on a routine basis with very small margins and very little dose outside of our target. And we're going to have the same questions, but now we're talking, more on an atomic or molecular level. How far do these radioactive molecules need to go in order to be effective? And I'm hopeful, and I think that a lot of these alpha emitting radioligands will be very, very effective and have much more limited toxicity. What did I miss? What else do you see in the future?
I mean, there's so many variabilities of what it could look like. I think you're right in terms of more indications, more disease sites being targeted. I think that we're going to see
personalized dosing with dosimetry.
Yeah, I hope so. Right. I mean, I think giving somebody 200 millicuries until they progress is pretty unsatisfying as a radiation oncologist. So I hope we see an advancement in delivering these therapies in a more personalized manner. Also, what gets me excited is there's some work being done on the combination of external beam and radiopharmaceutical therapy. I'm really interested to see where that goes. And it may be a little bit of a pie in the sky dream here, but giving concurrent radiopharmaceutical therapy with external beam therapy, can we
Sure.
decrease the dose limiting toxicities in external beam with a supplemental systemic therapy? Also, adaptive dosing. I'm really into adaptive dosing. I've started incorporating it into my practice with our SPECT-CT program. Looking at what do you do when somebody completely responds after 2 cycles, right? Or what is that threshold of waiting for the amount of avidity to build up again on your imaging so you can actually treat something rather than just the kidneys after somebody responds so well. And also identifying patients better. I think our outcomes will be better once we can select patients better. And there's some work that's being done, but I think there's a lot of work to do. Combinations of genomic signatures, radiographic biomarkers, and clinical biomarkers, being able to show that these drugs have a bigger impact, because although there is a response, it's statistically significant, OS and vision trial and PFS and subsequent trials, and then also significant impacts as we've seen in the NET space. I'd like to see that be a little better, right? And whether that use of an alpha or getting a little better at our patient selection, finding a signature that shows radiation resistance, radiation sensitivity, something like that would be really cool. So I think all the opportunities is what excites me. I think as a radiation oncologist, I also do a lot of breast cancer, and I run a lot of trials for our system in that space. And just running omission trials is not the most exciting thing to do, right?
Sure. Yep.
And so
Yep.
this is there's just so many options as an oncologist to be able to participate in what's building up of the future data and practice of radiopharmaceuticals is just, that's what it's all about. That's what's so fun about it.
And I think you bring up some really good points around like a lot of the growth in this and being able to select the right patients. And I think for what I've tried to impress on community practice radiation oncologists in our network is, hey, we want to be part and parcel with this. We want to be involved from the ground stage up, because what I really do think is that when you get all realms, you need the academic centers to run a lot of the trials, but they don't need to run them all. And when you get, community practices like yours, like ours, where they're running phase 1, phase 2, phase 3, I think then when you go to generalize that and you get FDA approval and you put this out into practices that aren't doing maybe a lot of phase 1, phase 2 research, you're more likely to get results that are similar to what the research showed if all that research wasn't just done in patients that are going to academic centers. I think you get better data, and that data is much more applicable to the general population.
Yeah, it's a great point.
Plus you can do it faster. When more people are doing the research, you generate that data sooner, and then instead of 10 years before we get this, we get it in 5.
Yeah, and I'd love to empower our fellow radiation oncologists to get engaged in these trials, and for that purpose.
Absolutely.
We've got a window, we've got this attention to this exciting paradigm. In order to get these trials done, it's more complicated than immunotherapy trials, than ADC trials. It takes a huge multidisciplinary effort, and it takes a lot of preparation. What can we do as a field to support it and get the work done, advance the field, be a part of it, and ultimately that being translated into improved outcomes for our patients, right? And helping them live longer, helping them have better quality of life, helping them have more options. And that's ultimately what it's all about.
And that is one thing when you talk about quality of life. You read the papers, you see the outcomes, you see the low toxicity. But to actually treat some of these patients, I think is very, very fun, because you give them those first couple of doses, and in my experience, not all, but most of them are going to say, hey, I'm feeling better than I was. I have less pain if they had pain, and very, very limited side effects is typically what I've seen. And that's been reassuring to me to say, hey, like in general, and certainly you have some patients that get more side effects, but in general, these are therapies that, because they're so targeted, they are better tolerated than a lot of the older radiopharmaceuticals that we heard about from 15, 30 years ago. And that I think is amazing to see where this field has gone and hopefully where it continues to go.
Well, Dr. Funk, what a great conversation about a field that you and I are so excited about mutually. What are some final departing thoughts here as we conclude our episode? Any final words of wisdom or words of encouragement for those out there interested in and engaged in this field?
Yeah, so I'd say, if you're not doing it already, learn what you need to learn to get involved with it. If you're already doing it, keep at it and try to build on it a little bit more. I think the growth in this field is in part going to be driven externally, but also as folks like you, as folks like the other radiation oncologists in our network get more and more involved, we'll get better tools to be able to deliver this. And as I think you said it really well, better outcomes for patients, more options for patients. That's the goal. And this is an area where there's going to be an explosion, and it's fun to be a part of it.
Yeah. Well, I agree. It's a great time to be a radiation oncologist. It's a great time to be in this position to take care of our patients in this exciting and advancing way. I want to thank you for your time so much, Orion. Looking forward to hearing more about the great things you and your colleagues are doing there, and look forward to the next time we connect.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.